Hey, good morning, everyone, and welcome. I know it's a Friday morning at 8 a.m. and people tend to come into the sessions at their own pace. We're grateful to all those of you who have already joined. My name is Danielle Martin. I'm a family doctor at Women's College Hospital, and I'm the chair of the Department of Family and Community Medicine here at the University of Toronto. And so excited about this morning's New Horizons series event where we're going to talk about the role of peer coaches and peer counselors in our healthcare system and how our people with lived experience in the health system can help to provide better care to those who need it and extend the capacity of our teams in this time of human resource crises. So I welcome you all, and I would encourage everyone to please introduce yourselves in the chat. If you reply to everyone, not just host and panelists, and just say who you are and where you're zooming in from this morning, just to get a bit of a sense of community on this webinar. And please feel free to use the chat throughout the session to comment and react appropriately, of course, to things that are being discussed. But if you have a question that you want posed to the panelists, please use the Q&A function. So about this speaker series, a few words before we begin. This series has been going on for over a year now, and it is about really encouraging us as family doctors and academic primary care leaders to think big and outside of our own discipline, to look for answers about how we can improve family medicine and primary care, and to take advantage of the vast wisdom that comes to us from other disciplines and other ways of thinking about the world, including much of which is represented across our great university, but also outside the university as well. And so we look to the arts, we look to public health, community activism, social sciences, and more as we think about the future of family medicine and primary care. I want to say a few words about this beautiful image that you see on your screen, which I had the opportunity to see in the huge format at the current exhibit at the McMichael Gallery in Kleinburg not long ago. And if you haven't been to see this exhibit, I cannot recommend it highly enough. This is a photograph by a Canadian and Indigenous artist named Meryl McMaster, who is of mixed Plains Cree, British, and Dutch ancestry. And she does these incredibly beautiful images that have tremendous symbolism. And she says about this particular image, which is called "Lead Me to Places I Could Not Find on My Own," which I think really is emblematic of the intent of this series. And she talks about the way in which different people from all kinds of backgrounds over millennia have used the stars to navigate and find their way. And that as light pollution has grown, that our ability to do that has become less and less. But this image is taken in at the Badlands and Grasslands National Park in Western Canada, which is a dark sky preserve. So a beautiful place to really be able to see the stars. And she says, perched atop her hat, because this is a self-portrait, as many of her images are the indigo bunting birds who use the stars to navigate. Carrying the universe, she says, they lead me to the stars as I seek answers in the sky. And I just have found this to be a really inspiring image and a really beautiful metaphor for what it is we're trying to do with the speaker series today. So I want to acknowledge Meryl McMaster's incredible work and the ongoing contributions of Indigenous peoples in this country, not only the land, but the arts, academia, and many, many other ways that our Indigenous colleagues contribute to the richness of our experiences. So with that, then let's leap right into a new way of thinking about navigating. And I want to welcome our speakers today. We have several peer coaches and peer counselors here to talk to us about this question of what can peer counselors do, or peers do, that family doctors can't. A bit of a cheeky way to phrase the title, but the idea really is, people with lived experience have a tremendous amount to contribute in our healthcare system. And as we think about the future of our discipline, we want to honor that and learn more about it and think more about. So I'd encourage all those of you who are healthcare providers and researchers on this morning's rounds to think about how you might do a better job of incorporating peers into your own work, especially during this time of human resources crunch. And to introduce the two programs that we're going to profile today, all coming out of academic family medicine, one in the emergency department and one in family practice, we have Doctors Bjug Borgundvaag and Ruth Heisey. Bjug, of course, is well known to many of you, is a full professor in our department and director of the Schwartz-Reisman Emergency Medicine Institute. He's an MD, PhD, and has spent much of his career working on how to improve care provided to patients in the emergency department. And he's a tremendous leader in our own DFCM. We're really grateful to have him here this morning and more importantly, as a member of our team. And Dr. Ruth Heisey is the head of the Department of Family and Community Medicine at Women's College Hospital. And in addition, and she's an associate professor here in DFCM. And in addition to being a family doctor, she's also a GP oncologist with clinical expertise in breast cancer. And in her work with the Canadian Cancer Society, she's really helped to lead the way, including in the establishment of the Peter Gilgan Center for Women's Cancers at Women's College. We're really grateful to Ruth for her tremendous leadership on the DFCM executive as well. So thank you both, and the peer coaches and peer counselors who are the real stars of today's show will introduce themselves in just a moment. But we wanted to take just a minute to level set and invite Ruth and Bjug to tell us a little bit about the Better Women and Pathway to Peers programs before we hand it over to our peer workers. So over to you, and thanks so much.
Thank you, Danielle. I think I'm starting, so if I could have the slides, please.
You know what, Ruth, actually, and I'm sorry to interrupt, can you just go back to the slide, Brian, with the introductory? I think actually, if you don't mind, we're going to take a moment to introduce our peer workers to begin. And so I'm going to ask Azmina to start. And if you could just say a little bit, Azmina, about yourself, the work you do, and why you became a peer coach, and then we'll go through the peer workers before we begin the formal presentations, if that's okay.
Thanks, Danielle. Hi, so my name is Azmina Chahani, part of the Better Women cohort for the Somerville program, and was trained about 2 years ago now. I really love what I'm doing as a coach, as a like a player with the patients or with the clients. The reason I went into this is I have a background in healthcare, past 20 plus years in Canada. So I do know how important screening is, and what the chronic diseases, how they can be prevented just by early screening. And plus volunteering is my passion. I love to volunteer. I've done that, I think, all my adult life. It just gives me great joy just to share whatever I've learned throughout the years. I don't have lived experience as a cancer patient, but I know people in my family who have gone through this and how stressful it is. And in terms of how a peer counselor, which I am right now in my role, it really is like holding the hand of the patient or the client and just walking them through to the goals that they are supposed to reach. So it really gives me joy, and it's learning for me as well as I go through the process. And I just love what I'm doing, and I think it's a privilege for me.
Thanks so much, Azmina. Christine?
You hear me? Yes. Hi, everyone. Thank you for inviting me to this forum. I have been actively volunteering as a peer health coach with the Better Women program through Women's College for the last year and a half. And so our goal is to provide ongoing support to these women to help them reach and maintain their health goals. It's a 6-month journey with each of these participants. So it really is about that partnership and helping them achieve those goals that they would like to get to. For me, the reason that I became, or this Better Women program spoke to me, is that 8 years ago, I was diagnosed with a very aggressive form of breast cancer. And that resulted in 6 rounds of chemotherapy, a double mastectomy, and a month of radiation. So I'm grateful that there were these curative treatments for me, but it was terrifying and exhausting. So although I don't have a healthcare background, I feel now that it's my purpose to serve other women based on the experience that I've gone through. So I really help them realize the importance of self-care, focusing on themselves, and really hoping to prevent what happened to me to happen to someone else. And if I could do that for one person, then my life is complete, and I can drop the mic, so that it's been very rewarding for me. Thank
Thanks
you.
so much, Christine. Jordan?
Hi everyone, I'm Jordan. I'm one of the peer support workers in the Pathway to Peers program at Sinai Health in the ED. I felt really drawn to this role because I realized that when I was struggling with my own mental health, and when because our program is mental health and substance use based. So as a youth, when I was struggling with my own mental health and had to access, acute care in the ED or wherever that be, I realized that although I'm somebody that can really self-advocate for myself on a daily basis, like I feel that I'm really good at that and advocating for others, in my time in crisis or in my time struggling, I could not advocate for myself. And I could have really benefited from a peer support worker in that time, not only to hold space and be able to just provide that layer of things that I wasn't really getting from the clinical perspective, but also just because I didn't have somebody to look for those missed barriers and look for, things that maybe weren't working in my care. And I just feel that it's really important to have somebody sort of viewing things really holistically. And so I felt really drawn to the role because I wanted to be able to provide that for people and be able to help other folks feel heard and that sort of thing. And I've been in the role for over 2 years now.
Terrific. Thank you, Jordan. And over to Sydney.
Hi, everyone. Thanks so much for having me. I'm Sydney. I go by she, her pronouns. I'm one of the other Pathway to Peers at Mount Sinai Hospital in the Emerge department. I've been in the role for a year now. And what's one of the reasons I've been drawn to the role is I think the mutuality and the relatability that peer counselors, peer support workers can bring. When I was going through my own mental health and physical health challenges, I had doctors helping me with my physio, doctors helping me with my medications. I found that the peer support worker really brought an aspect of relatability, mutuality in a shared struggle of mental health. And what I've really enjoyed about this role, and I've found something that's really meaningful about it, is that the mental health aspect isn't just stigmatized. It isn't just not stigmatized. It's actually a superpower to have struggles in mental health. And I found that this mutuality and that has been mutually healing, both for patients that I've had the privilege to interact with and partner with, as well as for myself.
Thank you all so much. Extremely well put. And we look forward to hearing a lot more about your work from you directly. And we will now pass to Ruth and then directly to Bjug to tell us just a little bit about the structure of these two really interesting programs.
Thank you. And thank you to the peer support counselors, because it's really heartwarming to hear the words that you use and the fact that you are benefiting from the experience as well, and talking about holding the hand and mutual gain. I think this is a really powerful tool that we have that's currently underutilized. So what is Better Women? Well, Better Women is a partnership. It's a program that's a partnership between Canadian Cancer Society and Women's College Hospital. We're currently offering it at 3 sites. So it's for women aged 40 to 68. It's being offered at Somerville Family Health Team, at Barrie Family Health Team, and at Women's College Academic Family Health Team currently. Next slide. To really understand what we're trying to do, we have to understand all of the evidence that this is based on and what were the grassroots. I mean, a Better Women is essentially an adaptation of the Better program. So the Better program itself is something that's been heavily researched, heavily evaluated in a very systematic and structured way by DFCM, University of Toronto researchers in collaboration with those in Edmonton in Alberta. We have 10 years of data on this. It's been heavily studied and heavily evaluated rigorously, and it is a very effective program. So what is it? It's a program intended to advance the health of Canadians and contribute to sustainable healthcare system through improving chronic disease prevention and screening. So ensuring that people get the cancer screening that they should have, and trying to help them to improve those risk factors such as smoking, alcohol, poor eating habits, and inactivity. How does it work? It works by training healthcare providers in primary care to be prevention practitioners who work with patients to set their own personalized goals to improve their healthier behaviors in cancer screening. I think this is kind of the secret sauce of this better program, is that the patients themselves are setting their own personal goals. So it's one thing for a family doctor to say, you know, the evidence suggests that you should be active 30 minutes a day, 5 days a week, when you're saying that to somebody who's really relatively inactive. How do you get them off the couch? And you know, that's too big a spread. You need to let the patient figure out what is their motivating factor, because it isn't going from 0 to 30 minutes a day, 5 days a week. That's just too much. So by having them set the prevention practitioners work with them to set their own personalized goals, which may very well be something, you know, similar to, hey, my dog wants to go out for a walk. I really want to fit in my favorite dress for my daughter's wedding in 6 months. And so let's marry those two and figure out how we can actually improve activity and fit into that dress and keep your dog happier in the morning. And so it's a win-win, but it's the patient who sets the goals that they believe are achievable to achieve their behavior shifts. This works. We know that at the 6-month point, we improve healthier behaviors in cancer screening by 37%. And I would encourage you to look at this website here, which goes very clearly through all of the various settings that this has been adapted to and studied in, and the rigor of the evaluation metrics. Next slide, please. So what we've done is we've thought, hey, we can do even better. What we can do is develop a training program to train Canadian Cancer Society volunteers to become peer health coaches who partner with these prevention practitioners in primary care to provide women with further support to meet their healthcare goals. Like, there's nothing better like a peer to really motivate you, stand alongside you, and hold your hand, like we heard Christine say. Or maybe it was Asmina, I apologize, I forget which one said it, but it was a lovely picture in my mind because that's really what you are doing. And also to make that behavior habit, because these peer health coaches will support that woman for up to 6 months. So maybe the woman's able to adapt to shifting the behavior, but maybe not to sustain that behavior. Next slide, please. So this is, of course, being rigorously evaluated as well. And we have recruited 127 of the 408 women that we need to recruit to date. We have trained 66 peer health coaches, and this training program is in collaboration with UHN and Dr. Jackie Bender, who developed the training program for us. We do have some early data on the effectiveness of this peer health coaching program. And I will say it's a a rigorous program. There's 52 competencies across 8 domains. There's, you know, I'm sure that the participants would say that, you know, they've learned a lot in this program. But what some of the comments and the early data that we have is that the subject matter was really very good in how it was taught. The instructors were excellent. The role plays were sort of the meat of the program. They really like to have some sort of real world coaching on how to communicate with an actual client. Next slide, please. We know they're highly satisfied. They have 9 out of 10 in the satisfaction scale. And we know actually that they feel really, really competent to perform the metrics that were incorporated within the program. And within the program, most of it was based on motivational interviewing, brief action planning, supporting people in behavior change. But there was also a very big portion of anti-oppression and cultural safety, which we're very proud of. And we know that that has really resonated with the coaches. Participants, we don't have the formalized data yet, but this is unsolicited data that we have from our participants. The program must be available to all women. The combination of metrics from our doctors and the hands-on application is essential to our health. This program has made an excellent start to what we all know to be the next logical evolution for proper healthcare in the medical community. Let me know when it's over, because I'd really like to be either an ongoing participant or a wellness coach, which I think is really a testament to the value of the program. Program was excellent. My coach was fantastic. I like that she respected the boundary about not discussing my weight. And then the third one, at first I was doing the exercise to be accountable to my coach, but then as time went on, I did it because I loved it. And now I'm accountable to myself. I know I'll be able to carry it on my own. So this is really the ultimate goal, is that we're helping to shift the behavior and empowering the woman to be able to continue this behavior on her own. Next slide. And none of this would be at all possible. I mean, again, partnerships are really important in healthcare and sustainability of healthcare. And I have to say that I really commend the Canadian Cancer Society, because, you know, we're not only trying to reduce by shifting these behavior and reducing chronic disease. It's not just cancer that we're hoping to reduce, because, you know, there is a belief 1 out of 5 cancers can be preventable by increasing healthier behaviors, but we're also helping to reduce the likelihood of developing heart disease, high blood pressure, osteoporosis, mental health challenges. You know, it's much broader than just cancer. And I have to commend the Canadian Cancer Society for thinking beyond their walls. So they've been really effective at working with their good project managers. They helped co-develop the program. They have a lot of expertise in this area. They're embedded within the community. So it really is a beautiful match. And we look forward to having the final results of this in about a year or so, I hope. But lots of encouraging early results. Next slide. And this wouldn't be possible without the support of the Public Health Agency of Canada, who is funding the multi-sectoral grant in collaboration with Canadian Cancer Society, Women's College, and the Peter Gilgan Centre for Women's Cancers. Thank you.
That's great, Ruth. And I want to say, and we'll get to the discussion later, and if people have questions, either for Ruth or for your coaches, please put them into the Q&A. But, you know, I think this program, because it is a partnership with CCS, is both an amazing example of how people with lived experience can contribute to prevention, and really working upstream in primary care, which is amazing, and also to spread and scale. So really, you know, having a partner like CCS gives you automatic reach across the country, which has tremendous potential impact for people across all of Canada. So congratulations to you and the team on your amazing work. And now I will switch to a different environment, but a similar premise, and invite Bjug to tell us about the Pathway to Peers program.
Thanks so much, Danielle. Thanks to everyone who's joining today, and we appreciate this opportunity to share our experience with our peer support program in the emergency department at Mount Sinai Hospital. I'm going to keep my comments hopefully as brief as possible so that you can hear about the amazing work that Jordan and Sydney do and have opportunities to ask them questions. Just a little bit of a background though, for any of you who have a young person in your practice or have young people in your house, you will be aware that over the last decade, and this predates the onset of COVID by a long time, there's been a significant increase in sort of mental health related problems, specifically in the young adult population. And we've been seeing this a lot in the emergency department. And I know some people don't think that emergency medicine is primary care, but much of what we do is primary care. And we see these folks and they come at a time of distress because we're open 365 days a year, 24 hours a day. You don't need an appointment, and we never turn anybody away. So often there's no other place to go at a time of crisis. The process in the emergency department for handling many of these problems really is to make a medical decision about whether somebody is ill enough to require hospital admission. The problem is we don't have much else that we can offer people in distress, and we really wanted to try and see if we could do something about that. One thing I've learned from speaking to young people who've been in that experience, had those experiences, is that over time, because the nature of these problems are that they're difficult to manage and they can persist, people come and have negative experiences in the hospital. It creates a sense of distrust and really challenges in trying to communicate and trying to advocate for those people. I learned about peer support from a colleague who'd started actually our community partner. It's called Stella's Place. And I thought, what a great idea if we could manage to do something like that in our emergency department. So even if we don't have something specifically we can do, at the very least, perhaps if we had a peer supporter in the emergency department, we may be able to make a difference in that young person's life. Could I have the next slide, please? So this is the genesis of the RBC Pathway to Peers program. We were very fortunate. We approached the RBC Foundation along with our hospital foundation. They provided 10 years of funding to launch this project. Specifically, we're about 5 years into it. Our program is a collaboration with our community partner, as I mentioned, Stella's Place, which is a leader in training peer support workers. And really the goals of our program are to improve trust, connections, and outcomes for young adults aged 16 to 29 years of age. We chose this age group specifically because this is when many young people are going through important transitions from into adulthood. And the prevalence of these kinds of problems, I think, is highest in this particular group. And we focus on young adults with mental health and addiction-related problems. The other thing that's been amazing about this project is that our peer support workers have joined committees in the hospitals and act as advocates for young people and people who suffer from mental health and addiction-related problems, and they represent that voice now in hospital-on-hospital communities. So they're involved in reducing stigma in our emergency department. They participate in hospital committees, presenting that point of view. And so it's been beneficial beyond just the walls of the emergency department and just within the scope of seeing people in the emergency department. Could I have the next slide, please? So our project provides in-person, real-time peer support to patients using this completely novel role that we've developed for the emergency department, where we have young adults with lived experience who meet people in real time, face to face. It's not a referral, it's not a card, it's not a number you call when you leave. These are people who come and hold space with you in the emergency department. And they're people who look like you and sound like you and have experienced the kinds of problems you're experiencing today. That makes a very, very powerful connection that is very beneficial. Our peer support workers, there's a variety of different models for this, but our peer support workers are fully integrated into our ED team. They're employed by SREMI. They have access to the the electronic medical record. They document their visits. They're bound by all the hospital privacy and all the other policies that you have to live with when you live in a hospital environment. And that's really helpful because everyone on our staff knows our peer support workers. Our peer support workers are very comfortable speaking to anyone on our staff, and it really fosters a sense of collaboration and integration of that role. We're trying to measure outcomes, and we're doing a complete, we're a research institute and an educational institute. We're doing a complete evaluation of our program. Part of it is complete. I can tell you, I wasn't sure, emergency nurses and doctors are famous for making house staff and outsiders cry because they can be a little bit jaded and vicious at times, and I was afraid how our peers were going to be received. I can tell you our staff love our peer support workers. After a very brief period of time, they learned they provide different sort of quality of care and kind of care, something they cannot do. And they really see it as an added value. So our preliminary or our evaluation of providers has shown that it's extremely popular. We've been doing surveys with our patients. We're in the middle of doing a qualitative project right now where we've been interviewing patients when they come to the hospital. And we're going to do also an formal evaluation using ICS data, looking at other important health outcomes. And so all of this is going to be hopefully completed within the next year. Next slide, please. One of our goals, peer support is not accredited by anyone. It's not, there's no college. We would like to have our program accredited by Peer Support Canada. We've been working together with Peer Support Canada towards that goal. And we want to develop a process so Jordan and Sydney and our other peer support worker, Bella, have been giving presentations at conferences locally, nationally and even internationally. Every time they give a presentation about our project, we are inundated with questions. How did you get this amazing program going? How did you fund it? How do you train these people? How can we do the same thing? So we're in the process of developing a training program, and we hope that if we can establish funding, we'll be able to provide training for other peers and other peer support managers. We'd like to expand this project across the province or across Canada. We've been working recently with the folks in the BC interior. They're going to be launching a Peer Support Canada very soon. And we'd like to expand this role to include an additional aspect. We cover about 70% of it, but there is this role called the Substance Use Navigator, which has become very, very popular in California. And we're hoping that we're going to be able to expand our peer role to include that. Next slide, please. So progress to date, we've created this new role. We've hired a project manager. We're in the process actually of hiring a manager now. Unfortunately, our project manager left our program after 4 years, but we've just posted for another one. We've got a partnership with Stella's Place. We've developed our training material. We've had a total of 5 peer support workers. One of the beautiful things about this project is our peer support workers come and they learn from their experience in the emergency department. I think mostly they found it very motivating, and they grow out of the role, which initially horrified me because I didn't want to have to keep looking for amazing people. But when I think about the trajectory of somebody who's suffered from these kinds of problems and been stigmatized, and now has, I can't remember if it was Jordan or Sydney said, but that lived experience kind of becomes like a superpower that makes you a very special person, that gives you credentials that can't be trained or learned any other way. Our peer support workers go through that whole evolution, and then they leave us, and then they go on and they go to university and they go to other jobs. And I think it's a beautiful thing. We currently have 3. Our program to date has seen about 5,000 young adults. Next month, May, is our 3rd anniversary. So the program is extremely busy. We have about 72 hours of coverage a week in our emergency department. And as I mentioned, we have very positive evaluations. If we could just have the next slide, please. I'll just, a couple of success stories that are always fun to share. Our peers send me these things all the time. Honestly, I well up sometimes, and they make me want to cry, which is embarrassing, but it's the truth. It's such a beautiful thing. If my first experience weren't enough, I had a second recent experience with a young adult in a mental health crisis this past week. My son's girlfriend ended up in the Sinai ER, and although she ran into the obstacle of not being able to get continuous psychiatric care, and of course there were no beds available, the peer worker at Mount Sinai Hospital was the most helpful part of the visit. The peer was also a U of T student, informed her of financial benefits she was unaware of for private counseling covered as a student, which even student health at U of T didn't inform her about. I think the peer workers are amazing. Next slide, please. Here's one of my favorites, very succinct. You can read it for yourself. This kind of thing is just absolutely beautiful to me. And these are not words that would ever be said by people who came to our hospital as young adults with these kinds of problems prior to our peer program. So I'm really, really pleased that we're able to do this in a world where COVID has turned everything upside down, and everything in healthcare is terrible. And the emergency department is, as always, the epicenter of how terrible things are. This is the one program that's been just a beautiful success story. And we're very proud of it. I'm going to let Jordan and Sydney and Christine take over.
Thanks so much, Bjug. Thank you all for sharing these 2 extremely inspiring programs. I'll ask you, Brian, to unshare. I think we're through the slide presentations. Yep. Yes. Okay. So we'll unshare so that we can all have a little bit of a dialogue. And I want to begin by asking our peer workers, who I want to honor your courage in coming to talk about your work with us today, and thank you for that. I'm wondering if any of you feels comfortable sharing a little bit about a story or a case that you think exemplifies the role that a peer worker can play in the health system. When an experience that you've had yourself with a patient or a family member that you think we should all be, that tells us what we need to know about the function of this role in the health system or the potential function. Any volunteers? Please go ahead, Asmina.
Thanks. So I'm just finishing up with one of my participants. It's almost going to be 6 months now. And honestly, it was such a learning experience for myself as well. Because going into the training, you just look at the black and white things on the paper, you know, how to connect with the client and how do you motivate them. But once you actually are talking to the client, it is completely a different ground. It's like you have to meet them where they are at their journey. And everybody is different. So you can't really apply whatever you've learned on the thing. You kind of go along as you finally know the client. You make the connection. And then once you make that connection, they themselves are going to find the solutions according to what works for them. And that was really enlightening. You know, it's not like I'm supposed to write a prescription for you. You yourself know your life and what works for you and what doesn't work for you. And it's kind of, you're on the sideline just cheering them on. And, you know, some weeks are good. She was really right on point. She was exercising. Now she's regularly meditating. She's taking a walk with her dog, but her work is the biggest challenge. And I wouldn't have known unless she herself, you know, told me that. And this is what her life is. She's sitting on the desk like 12 hours a day. So you kind of work along with that, okay, fine. She knows what's good for me. I have to eat healthy. I have to exercise, but according to her lifestyle and her work, it wasn't allowing her. So we kind of go along with what works for her in her life. And then as she went along, now she's almost like near the end of 6 months, she herself, when I call her, she herself just starts to, I meditated really regularly this whole past week. I exercised 20 minutes. I couldn't do the full hour, but I'm trying to do that. And I went out like every 2 hours, I was getting up from my desk. I was taking the dog out for a walk. So small little things that are like really make a huge difference in her. So her blood pressure has almost normalized now. And she's going for her regular screening, but it just gives me such a joy that small little tweaks, which you know, on a bigger scale, you would think, oh my God, it's not going to make a difference, but it does. And I can just feel it in her voice when she's talking to me now. Like, it's like she really feels accountable and she feels very proud of achieving those small little successes. So I find it really gratifying.
I think this theme of meeting people where they're at, I've heard, I think almost everyone on this screen use an equivalent phrase to that. And it is something we talk about in family medicine and in healthcare. And I think we're not always so good at living it. And I'm hearing that perhaps a peer coach or a peer worker may sometimes be better placed to do that, in part because sometimes you've been there in a very personal kind of a way. So Joyce has asked in the chat, of our two Pathway to Peers colleagues, if you would be willing to tell us a little bit about what that's like for you, meeting people where they're at when you yourself have been there in some version of that, and what do you do to guard your own mental health while supporting your peers? And can you tell us a little bit about that?
Yeah, I can talk a little bit on what we do to ensure our own well-being, especially in the role. So we do have weekly like community of practice meetings where we debrief a lot of, difficult situations. We also rely a lot on each other to debrief difficult situations. And we're constantly sharing sort of like resources for like self-care and ways to just like maintain overall wellness. There have been, I think part of the question is, what are the main concerns and issues that we've dealt with? And I think like some of the main concerns and issues have been when you come from a place of lived experience, sometimes I think tackling like boundaries can be a little bit different. And so in the role, there have been times where we've, sort of had like potentially like boundaries pushed a little bit, or we've been sort of like unclear about what we should be like exerting as boundaries. And so our community of practice have been really helpful for that. We've got a community partner from Peer Support Canada who works with us a lot to ensure that we're staying within the values of Peer Support Canada, and that we're able to sort of exert boundaries in a way that feels comfortable. And and also that self-care piece is like heavily tackled in our COPs too.
This notion of a community practice, I think, is really important. And I know we've heard this also from our the participants in our Patient Family Advisory Council, which is a different, kind of role, of course, but this notion that you can't just pull a single person in with lived experience and plunk them on a committee, that people need to feel that they are in community with one another in order to be able to, first of all, have the impact, and secondly, that mutual support is key in being able to continue the work, which can be taxing for a person with lived experience. Sydney or Christine, I'm wondering if you want to add anything about your own experiences to this. Go ahead, Sydney.
Thank you. I guess a challenge that I had when I first started the role was kind of this mindset of thinking, what if I can't completely exactly relate to every situation that every single person has been through? How am I going to support them? And I think when I think about having a perspective of lived experience, it's not really about having like a carbon copy of events and like circumstances that patients have been through, but finding mutuality in our feelings and reactions and responses that are kind of thrown at us. And I think that common ground and experience is kind of where the important cornerstones of peer support is. And I think this was illustrated in a patient interaction where patient came in, master's student, who was experiencing very severe shortness of breath and asthma. And I kind of zoomed out and asked, what has been working for you in the past for coping with this? And then it sort of went into a realm of, I also have complex PTSD. Breathing exercises actually aren't helpful for me. And that's sometimes assigned to me by clinical professionals to try breathing exercises. And that actually, she called it bookmarks for trauma. It's kind of bookmarks trauma for me. So it was a willingness for me as well to sort of lean into that conversation and be willing to be changed by what the patient was saying to me. And also realizing when I was in my own recovery for stroke, my left side weakness, it wasn't helpful for me to be let know that, body scans are helpful. So I shared that lived experience with her as well. And the way that the conversation went was, she let me know it was just so helpful that I had lived experience. She felt that she didn't have to explain herself as much to me. So it's important for me to remember that I don't need to be a carbon copy. Lived experience is about zooming out and having those shared feelings around different struggles, mentally, physically.
That's a really helpful point, and important for us all to remember, because it would be impossible, of course, to duplicate every single person's experience, but being able to have a way, a doorway through which you can relate sounds like it is an important part of the trust building process. Christine, did you want to add something to that? And then I've got a question for Ruth and Bjug as well.
I just one of the main learnings for me was not to assume that the goals that the participant had put in place with their prevention practitioners were actually that the participant was actually doing them 100%. So as with many of us, when we do set goals, in January, we're like, I'm going to exercise 5 times a week. And then, you think it's good enough that you maybe told someone about it or wrote it down. But then when you actually have to start doing it, that's where the challenge is. So I've really just over the couple of participants I've had really, again, going back to where are you now, right? Like how are you progressing now? And are these goals realistic for you? And my favorite question to ask them is, how can we make this easy? right? Like what is it that we can do to make this easy? If there's any sort of obstacles, or if your goal was to exercise 5 times a week and they're only exercising one, that's okay, right? You have to, like, let's start small and then celebrate the small wins and work from there. And then they get the momentum to increase it. And it's really about evoking the strength, and they have the tools. Like the last participant I was with was really good at planning for her life and her work. And then she kind of realized, well, what if I planned to work out on, say, like put it in my calendar Tuesdays and Thursdays? And then she was like, oh, yeah. And then so she started doing it and then started feeling really good about it. So really trying to understand how to make it easy.
And just out of curiosity, how long is your average session as a peer coach, Christine, with your?
So the intro session, the first time we meet with them, is about a half an hour to 45 minutes to really flesh out where they're at, their goals, how they're progressing, how confident they feel about these goals. And then after that, we set weekly touch points for about 10 to 15 minutes. And I think that is one of the main benefits of the program, because I think Ruth mentioned it, it's like the participant feels accountable to report, oh no, I'm meeting with Christine on Friday, I better have done something. And then eventually they want to do it. And then they get into a maintenance phase, and it's a beautiful journey to watch.
And I think that all those of us who are practicing, in office-based family medicine would say, like, what an amazing gift to have also that time, that time to
That's
spend with the
exactly.
person thinking
Yeah.
upstream and working on preventing illness rather than always responding to the downstream impacts. And I think it's wonderful that your role allows for some of that time. And Sheila has done in the chat has a quick question just on this follow-up for our Pathway to Peers program. And it looks like Shelley McLeod has helpfully answered it, that there is a little bit of follow-up, but not a ton of ongoing follow-up. It would be amazing to imagine how the peer support worker in the emergency department might eventually hand someone over to a peer worker in the family practice, so that we could get that continuity over time and space. And maybe that's something that we could think about in DFCM. Bjug, there's a question for you in the Q&A about evaluation, and I might throw it to both you and Ruth, because of course, people need to get paid for their work, and these models need to have a return on investment. And I know that some models involve volunteers, but there's only so far that a volunteer program can go in our healthcare system. And so, how do we frame the evaluation in order to help policymakers see a so-called return on investment?
Maybe I'll take that first, Ruth. It's amazing to me. That was Shelley McLeod is our research director at SREMI. She is a PhD epidemiologist, biostatistician, and the brains behind the organization. It's amazing to me that governments institute policies with almost no thought about how it's going to work, or whether it'll work, or whether it's beneficial or not. And Shelley just did the provincial evaluation of the virtual urgent care program, and could talk more about that. It continues to get millions of dollars of funding with surprisingly little evidence to support it. With RBC, we approached them because we were interested in this area, and sorry, my daughter's dog is visiting. I apologize. The thing that sealed the deal, we're not youth mental health experts. I'm an emergency physician. We work in an adult hospital. But the fact that we run a research institute and we're going to do a formal evaluation of this was an extremely strong selling suit for RBC, and I think was the thing that actually helped seal the deal for us. So doing an evaluation, having any evaluation plan is very, very beneficial. And And I think, we're doing a proper formal evaluation. And I think in the end, if you can offer that to a funding agency, it's extremely powerful.
Anything to add to that, Ruth?
Yeah, oh, I just love that pet therapy. Thank you for that, Bjug. I think I agree. We have the work that we're doing is being rigorously evaluated. We have very good data for the Better program that it does work. We're confident that the addition of peer health coaches will only make it better. We are looking at all of the important metrics to show objective improvement in patients' health, in women's health. So it's there. And the reality is that when you connect with the policymakers and the people in healthcare, you get somebody to buy in, but there's such turnover in the healthcare world that, you have your allies, and then it seems that those allies move on to do something else, and you have to make new allies. You're always currently trying to get this in front of people. So I'm hoping that you, Danielle, can help us in this initiative. And I think this is an opportunity for DFCM to lead in this space, because really we have the data, we have what we need, we know this works. Again, there's still a little more data we can provide, obviously, in our space, but we've got as much good data as many of the things that have been executed on a much broader scale with less compelling data. So we should be proud of this, and we are ready to go. It's just a matter of getting it in front of the right person, and Danielle, you're the right person for that.
Well, I'd do it or die trying, I always say. So, and I think, I want to ask a final question about equity deserving communities, because I think that one of the many lessons of the last 3 years has been that the most effective way to build bridges between a healthcare system that has not attended to large numbers of people effectively is to work through trusted people and trusted institutions in communities where people do feel safe. And so we saw, incredible examples of that in our own department around the COVID vaccination initiatives that were Indigenous led, that were Black led, the role of community ambassadors and outreach. And I just wonder if we're forgetting already some of those lessons as a health system. And to me, the work of peer coaches and peer support workers, while it's not exactly the same as the work of a community ambassador or a community health worker, it seems to me to be on that continuum of people with lived experience building bridges to those who otherwise haven't had good experiences or often don't have good experiences in our healthcare system. And I'm wondering if anyone would like to share a hope with us about what you think community members could do to help us address the human resources crisis we have. Is there a place in the health system where you would like to see peers, aside from the 2 great programs we've seen today? Are there other places in the system where you think peers and community members could really make a big difference? And where might we look next to build another wonderful program like the 2 we've heard about? Ruth?
Yeah, so we're already looking at next steps. I mean, this program has been tested and implemented in Indigenous populations. It's been tested in lower income populations, and it's been tested in the public health domain. Shown to be effective, but we're also now looking, we know that to shift behavior, the most powerful people that you can shift behavior in it is those who have the worst behavior and those who are struggling the most with food insecurity, so on and so forth, right? It's even more challenging for them to eat healthy. So yes, the next step is to embed this across our entire health team, for example, in the most marginalized and racialized communities, and work with people that are embedded within those communities, because those are the people that are trusted and respected. So it's ideally suited for that as the next step to reach hotspots and target hotspots. So I think that, and same with mental health support. I think that we're ideally, this type of program is ideally suited to meet the needs of those most racialized and marginalized communities.
Any other thoughts on this?
Maybe I could just add one thought, and I know you and I have spoken about this, Danielle, and I thank you very much for your support. But the place that I think comes most face to face with all of these populations is the emergency department. A lot of these folks are unattached; they don't have family doctors. We have many newcomers to Canada. I think it's a great opportunity to use the ED setting to try and create these kinds of connections with diverse communities. And sort of our view about interacting with the communities is not that the hospital should, have walls around it and it's full of specialists. And if you're lucky enough, in 6 months, you get an appointment to come in here. Our view is that we should be taking the expertise of the people in the hospital. We should be taking that expertise out into the community, using what we know, trying to amplify it and multiply it, and build, community resources, because there's zero chance our hospitals are going to be able to cope with all of these kinds of problems and the downstream consequences of all the kinds of things that are bad for people that we've been talking about this morning. So I think our best hope is to try and build connections with communities, use the ED environment as a good place to do that, and try and find community partnerships.
Well, you're speaking straight to my heart there, both of you. And I think, our department is really committed to looking at how we can build those innovative models that reach outside our four walls. And we definitely can't do it without the work of people with lived experience, like peer coaches and peer support workers. So I want to really sincerely thank the four of you for participating today: Sydney, Christine, Asmina, and Jordan. You've brought a really rich dimension to our conversation here. And I think, as we talk about all of these millions of people in the province who can't access care, who don't have a family doctor, who are waiting for specialist care, et cetera. And we think to ourselves, well, we better train more family doctors. We better train more family doctors. I mean, of course, we should train more family doctors, but there are many, many other team members, not to speak of nurse practitioners, nurses, pharmacists, PAs, and all the many other members of the team. But this is a place where I think we can really make a difference. And I think we should be really thinking as a department about peer workers as important members of the team that we could begin to support and build out in new ways. So thank you for bringing your expertise to us today. And I want to thank also Elisa and Brian for setting up today's New Horizons, and say that we have one more session before we break for summer. And, if I could give everyone on this Zoom an Oscar, I would. But since I can't, we have an Oscar winner coming to us on June 9th instead. To cap off our year, Sarah Pauly will be coming to talk about the arts and family medicine, and what we can learn from her incredible film, Women Talking, her book, which we've purchased 50 copies of to share with some of you who hopefully will be participating in that session. So we'll welcome a giant in our city, Sarah Pauly, to the next New Horizons. Mark your calendars for 8 a.m. And thank you so much, Ruth and Bjug, and our 4 peer support workers and peer coaches, for participating today. Thank you.
Thanks to you.
Thanks very much.